Good day, all, and welcome to the Teledigm Pulse podcast, your Rural Health Matters resource. Hear from your colleagues and industry experts on rural health issues and innovative care models that make a difference for rural hospitals, providers, and communities.
This is part 2 of a 2-part episode with Dr. Ryan Martin from Nebraska Pulmonary Specialties. If you didn't hear part 1, be sure to go back and listen to that. We had a great conversation with him, so we decided to keep the recording going and bring it to you in 2 parts. Hope you enjoy it.
Let's switch gears. There wasn't a significant focus on critical access strategy initially out of the gate. And of course, then entered the pandemic, and where it was sort of forced upon a lot of these hospitals the need to necessitate essentially caring for critical care patients in the critical access hospitals that clearly they were not accustomed to taking care of, certainly. And I think that one of the fascinating stories about Ryan or Dr. Martin, you and your team, has been the ability to be flexible and adapt to those situations. And I know you and I've talked about this in the past about the pride that you have in what was accomplished during the pandemic and through the critical access hospital networks, because we're in many of those hospitals, and then sort of the epiphany that a lot of these places had during and post pandemic on the success they had in taking care of a lot of these sicker patients as a result of having your expertise and your team's expertise available. So can you kind of describe maybe that journey into the critical access market and network, and then how that translates into where we're at today and your view on keeping more patients in critical access hospitals?
Yeah, absolutely. So, yeah, this was again part of when we started doing this. One of the things that I was really, I felt was important um, going into medicine, knowing what I know, having grown up with what I did. I felt like it was important to be able to try and keep people at home. It really was something that was core to what I wanted to do when we developed programs. We really worked hard for 2 years plus. Shane, is that right? To get
Yeah.
a couple of
Yep.
sites, one or two sites just that were critical access. But they were what these sites were is they were what I would consider, feeder sites. They were constantly sending stuff in, and in that regard, we were looking at this going, hey, you guys have a hospital that's right here. What can we do to help you keep people on site? And when we saw COVID coming, especially by what was that, maybe March, April, maybe, we really kind of hit the accelerator on this. But we'd had a couple sites before that were inclined to say, yeah, we want to be able to have, access to pulmonary patients. We have some of these. We want to make sure we're on the right track and try to keep people home. So we had a little bit of a pathway sort of outlined. And then as part of the pandemic, what really ended up happening is we just grew incredibly rapidly because there was an incredible need for what we were capable of doing. Typically speaking, oxygen demand is one of those things that is a transfer criteria. So if you're looking at, oxygenation and ventilation are two of the things that will almost always prompt someone to pick up the phone and ask for help, or a hospital bed in an intensive care unit. And obviously, when we got into the pandemic, and I know the stories are out there all over the place, but the ICUs filled up and there were no more beds to put people in. And what ended up happening is there was this recognition across a lot of smaller towns and a lot of critical access hospitals, really at a time when they all had to be looking and moving together in the same realm. What happened was we got busy with this. The growth in this through the pandemic was really incredibly striking. And it is one of the best applications that we saw the entire time we've done this. This is probably my favorite process, but the application of it was widespread. We were able to help facilities hang on to patients that they normally wouldn't have, and that could include things such as just really high oxygen amounts, high flow oxygen, things like non-invasive ventilation or mask type ventilation, things that again they would normally not be comfortable handling, and in some instances not dozens of, but definitely instances, there were many of them, where critical access hospitals were handling patients with COVID, pneumonia, ARDS type picture. They were handling mechanical ventilation, in settings that weren't really intensive care units. And what that did is that we were able to help them, guide the settings, manage the mechanical ventilation, manage the situation to a point where they were either A, improving and didn't need our help as much anymore, or B, get them transferred in to an intensive care unit. Um, and one of the best parts in all of this was the comparison of the data that showed Nebraska's mortality being where it was during that time. The bulk of our practice when this was in the state of Nebraska, and it was across 30-ish, maybe a little bit more number of facilities. We were able to really, I feel like we played a role in driving that mortality number where we stayed very low this whole time. That was a big part of it. But the other side of this is, you throw the pandemic data out of there and just look at what else we're able to do. And that's the world we're in today. We're back to, again, what would be considered more of a normal situation. What we're doing today, though, is still, we're still doing this. We're still taking care of patients in smaller towns. We're still managing people. And there are questions that come up of, hey, this is what I've got. Can you take a look? And whether this is COPD or a pneumonia, or in some instances, whether this is an acute infection and sepsis, or work of breathing, difficulty breathing, or in some instances, people know that they have chronic conditions and they don't really want to transfer. The question is, hey, can you look in? Can you guide us a little bit? Are we on the right track? Should we make any tweaks? It's been a very good collaborative effort to go through and do all this. So the critical access program really, we developed it during the pandemic. We grew it during the pandemic. We've kept it in the post-pandemic world, and it's really been something that has been useful. Um, I believe across multiple situations, and really still to this day, I think is keeping patients where they want to be, which is at home if possible.
Absolutely, and they definitely want to stay home. Almost 100% of the time. You might find a straggler that wants to go shopping post hospital visit, but I have a hunch of
Yeah.
99% of these folks want to stay at home. And I think that one of the challenges is sort of overcoming that fundamental uh, or sort of that legacy thought process from some of the, whether it's local providers or nurses, or in some cases families, or in some cases patients, in terms of the desire to transfer, and or the just what has happened historically. This is just what we do. We just
Mhm.
transfer these patients. And I know that you've had a lot of conversations. In fact, I mean, I'll get a call from you. Just I'll be driving down the road, and I get a call from Dr. Martin saying, "Hey, Shane, aren't we in hospital X?" And I said, I don't think we are." And well, they just transferred a patient, and this patient does not need to be here. We could easily be doing this where they came from. I mean, what's going on? Can't we get some stuff in there to keep the patient at home? And those are just, it's fascinating to have. That's just the beauty of having the team that does these types of activities, and then that patient hits the ICU or hits the med surge floor, and you get a consult, and you're going, I could do this very easily where they came from,
Mhm.
very safely. And it saves a transfer, it saves a ride in a box all the way to Lincoln in an ambulance, which again I did that for many years, many eons ago. And by the way, patients, their satisfaction in riding on a board or a cot in the back of an ambulance, any sort of miles of any sort, is not a highly sought after proposition for most folks. So avoiding that is absolutely of best interest. And so, what from your perspective, as you've talked with various local providers, physicians, nursing staffs, patients over the years, what from your perspective, what would you offer somebody who maybe is historically, if they need that, I got to transfer them? Well, what would you recommend they do in terms of some things they should ask either the administration or themselves or their partners, or the staff's on. What can we do differently to take care of some folks, more folks here?
Yeah, the first part in a lot of that has to do with what I would actually say confidence is the most important part in this, and that's not something that is transferred immediately. Um, you have to have confidence in your own abilities. You have to have confidence in the consulting individuals. You have to have confidence in the nursing staff, and really that's a large part of this. Is it takes some time to do this, and what we've seen in almost every instance is um, there has been a slow adoption in a lot of places because you have to break the model of this is the way we've always done it to change it to look at it and say this is now the way we do it, and that doesn't happen immediately, so it's a slower process to actually get those things changed. One of the things that we do fairly routinely is we do some site check-ins. We usually do those every 4 to 6 months, kind of a site check-in, speak with the physicians, usually chief of staff or nursing staff or respiratory staff. Um, but in a lot of instances, it's a slower adoption, and it really takes some time to feel out that this is something that we want to transfer. This is something we want to keep. A lot of people will still they'll still want to keep people, and that's what we were hoping to do. I do feel like in some of that there is definitely a level of anxiety the first few times this happens until we start to again re-ingrain that transition and how did we do things and now how do we do things, and that's going to be some of it. You just have to make those transitions, and it takes time and it takes a lot of takes phone calls. It takes again the consultation. In a lot of instances the consultation isn't the end of the road on something. Sometimes you can see a patient, you can make some adjustments to orders and leave a note, a consultation note, and of course it's read and it's looked at, and then if everything goes according to plan, which it doesn't always happen, obviously it's the real world and it's medicine, uh, but if it goes as planned, everybody's very happy with it, and they said, well, that was kind of the easy button. When the cases are a little tougher, and things don't go exactly as planned, it's not just okay. Well, we consulted once. It's hey, pick up the phone, call back, let us know. Hey, something's changed. What else would we do in this instance? And those types of things. So there needs to be that comfort, not just in okay, well, we're comfortable pressing the button to call. We're comfortable bringing the card in and seeing the patient. We're comfortable with that. There also has to be a level of comfort that it's two-way communication, that you can pick up the phone and call back and say, hey, how is this working? Depending upon the situation and the instruction, in certain in critical situations, a lot of times we will leave direct instruction in this patient with this. When this comes back, I need you to call me back so I know what it looks like. And that is again something that we're all in our group. That's something we're a big proponent of. We want the two-way communication. We don't want it to be unilateral or one direction. We don't want to just talk to people only and say, do these things. If something's changing, we need to know about it because we can always act on it. So that's a confidence in the system, and it is a difference. In smaller towns, there's not a lot of back and forth communication on an inpatient because of the nature of that. It's usually internal medicine, family medicine, or maybe pediatrics in a smaller hospital, but usually it's family medicine physicians, and
Hmm.
they're not used to having consultants at the bedside. And so that's one of those things. It's like, hey, not only did you consult us, but you're certainly welcome to call us back and say, hey, what do you think about this now? It's a little different. And that's one of the things that we encourage.
Hmm. Yeah, for sure. And I think you hit the nail on the head right out of the gate when you said, we had confidence. Our goal is to have confidence. And at the end of the day, anytime there's a fundamental change involved, which a lot of times there is in these situations, it's how can we take them down that path and yet add that and instill that confidence in that local provider and collaborate and work with that local provider to manage them up and manage their care up to be able to feel confident in taking care of more patients there locally, knowing that they have that expert in their back pocket that they can consult with at any time, or that patient, or can get in and see the patient at any time, and certainly round on that patient at any time. And then having the nursing staff have access, to the team around the clock is such a huge value add. And I think, speaking of value add, one of the things that we really strived to accomplish in the critical access market particular was how do you really increase the value proposition as a whole, and how do you really I've used this analogy a lot in terms of how do you keep as many patients in your sandbox as possible from start to finish to follow up, and around the continuum. And I think this program is really the cornerstone in a lot of those models, because of the ability to then tie in the outpatient strategy and program as part of the overall virtual strategy. And how we not only, and it's more, it is absolutely more than just an outpatient pulmonary consultation. It actually involves strategy on the discharge to get the patient the best care quickly, in terms of, you have that expert insight at the point of discharge on the inpatient side, in terms of steroid strategy post discharge, or transitioning that into an outpatient setting that should be seen by a pulmonologist within X amount of time. But then, so the consults are one thing, and being available is one thing, but then the ancillary strategies when it comes to PFT testing, and the ability to then help them build and bridge that gap and get into reading those PFTs. Can you kind of describe a little bit, on the uniqueness of this program, and being able to cover and manage all of those aspects, which really builds what I would call a significant pulmonary presence at the local level?
Yeah, actually, that's a very good launch point on that, and we'll talk a little bit. I think one of the things that in general is medicine isn't just episodic. I mean, some things are, right? You break an arm, it's a cast. If you get a cut, and you need stitches, it's an episode. But in many of the diseases that we treat, most of what happens is it's not an episodic event. It's a continuous event. And the introduction in a lot of instances to pulmonary service happens to be on the inpatient side. That isn't where it ends. It ends in the outpatient side. So there's the continuum, and really one of the things, and this is one thing I can say, Shane, I still feel quite confident in this. We're one of the, or maybe the only people that are out there doing the concept of continuum of care. This is not something you can get out of a VisiQ style system. It just isn't capable to do something like this. And this is also part of where you kind of look at it and say, well, how else can you do this? Pulmonologists do not grow on trees. We are a hard breed to find, and depending upon location, again, I like to look at it as, I don't want geography to be a limiting factor to getting somebody at least an evaluation. So when you think about it in that fashion, some of these things don't need to be dealt with as an inpatient side. And one of the things that, if you look at it and say, okay, well, if we built a critical access operation, and just an example would be if somebody had a lung mass, I don't want a physician to have to admit a patient to the hospital to consult me to look at a lung mass. What we want to be able to do is say, okay, well, you have somebody with a lung mass. Well, how about we figure out a way to get somebody scheduled to see them? They can come into clinic. We can look at this lung mass as this person is an outpatient. And again, like I've already shared, I can show them the image of their lung mass. We can talk about what is the first step in moving forward. We also need to look at medical histories. And obviously this is something we do on the inpatient side, but it's very common. It's a part of the outpatient world as well. You're looking at histories, you're looking at probabilities. We are looking at additional studies. What things do we need to look at? If somebody says, hey, I need to see this patient because they have a lung mass, the first thing that I'm going to look at is, can they tolerate a resection of this portion of their lung? Can we really move forward with trying to get to what's called curative intent? Meaning, can we go and take a look at that thing? If it ends up being a tumor, can we cut it out? Speaking very bluntly, can we get that done? Well, I don't want to have somebody wait 25 days to the next pulmonary physician appointment who may or may not be available, or have somebody drive 2.5 hours to be seen. We can do this, especially a lot of the more imaging based studies, very readily, very expediently, and with a very high degree of confidence to actually really advance that care, move the football down the field. That's really where part of this came up as. And we always looked at it as, do we have that capability to get an outpatient structure? Well, yes, of course we do. And the way we are set up, you're being seen by a pulmonary and critical care physician in clinics. When this person is needing to be seen, you're getting one of us. And we're reviewing the images, we're reviewing the pulmonary function, we're reviewing the history, we're calling and speaking with primary physicians. We're making sure everybody's included in the loop and in the outcome on this. So that was a big part of what we went into. But again, kind of going back to that concept of continuum versus episode, right? So you think about it, the last thing I want is someone having to be admitted for an outpatient problem. But again, some of those inpatient problems, that's their introduction to pulmonary service, but that's going to be a lifelong diagnosis. In a lot of instances, you think about somebody who has the diagnosis of COPD. Maybe they don't know they have it. Maybe they smoke for 35 years and they don't know that they have COPD. They probably assume they do, and it most likely won't come as a shock to them. But that's a person who is going to need pulmonary services ongoing, longitudinally, probably forever. And the diagnosis, the management of it, it's, as with every disease, it's getting a little bit more complex as the years go on. And as that occurs, it's not something that we expect people to really pull back from in terms of being able to all be managed individually, but more along the lines of, we work hand in hand with their primary physician. We will help manage disease, but really getting through that continuum of care and being part of that continuum of care is really what we're trying to do.
Yeah, and I think that's such a huge value add to not only the hospital and the community, but the patient, to be able to have that level of expertise available, and that guidance, and gosh, frankly, the quality of life that they're able to lead as a result of having those services available. Because really, at the end of the day, I don't have any data in front of me necessarily that to quantify this, but certainly I would think that if this is available and the access to this care is readily available at the local level, should theoretically increase the uptake and the compliance, if you will, of patients showing up for these types of appointments, as opposed to having to drive an hour, 2 hours, 3 hours to go see Dr. Martin in person, for example. Would you agree with that? Do you see that, or what are your thoughts?
Yeah, I've seen a little bit of this both ways. I've seen people who want to come down and see us, and then I'll see somebody and tell them, at your follow-up, we're not going to make you drive 2 hours to come see us. Let's plug in here. We'll go over stuff. If there's something we need to have people come in for, absolutely. If we have to do, again, some of our more specialized things, especially predominantly procedurally, yes, absolutely come down. In a lot of instances, we can get a lot of the information and sort of make plans on what somebody needs, without having to make that drive the first go around. And we have the ability to be flexible with scheduling. We can look at and say, hey, Dr. Martin has a spot here, Dr. Jarrett has a spot here, Dr. Fiedler, pick a name. We can find a way to get people seen, especially if we run up against these high priority items. If you have somebody coughing up blood, or if you have a new lung mass, or somebody has a collapsed lung, or if these are things that people want answers to rather rapidly. We want to be able to fit in that realm. And again, if you think about geography as a barrier, if we have to have somebody drive 150 miles, yeah, geography is a barrier. If we can figure out how to get them on the schedule tomorrow afternoon, and we don't have to go anywhere at all, but we can at least get some of this started with the workup, it really, I think, lends a lot of ability and a lot of credence to what we're doing. And again, we know with some of the advanced procedures, we're going to have to make some trips, but maybe we make a trip and we do two things at the same time, or three things at the same time, instead of three separate trips to do three separate things. you can really stack things up a little bit with good planning. And I think this program gives us a lot of those opportunities to, do the things we can do remotely, do the things we have to do in person, and limit that sort of travel, but sort of expedite the whole process.
Sure. No, I completely agree, and I think I'm interested in, as we kind of come to a close here. As you look back over the last 7+ years of doing this, and all the consultations that you've been a part of over the years, and unique situations and scenarios, think of one case that comes to mind. I'm kind of putting you on the spot here, by the way. We haven't really talked about this, but I think if anybody can handle this, it'd be you. I mean, that can handle this. But so let me think about one. So think about, give us an example of a case that you got involved in that was really, kind of a tense moment that you really felt. I mean, we've made such an impact across so many patients' lives over the last 7 years, and prevented just thousands of transfers. But can you think of one or two incidents that really resonates with you? That, gosh, good thing we were there. Good thing we were there right away to provide this type of consultative service. And not only were we there right away, but the patient then didn't need to be transferred. Does anything ring a bell? And I'm sure you're rolling through your head going, I've got 50 of them. How much time do you got? But how about one?
Well, I have a couple in specific that I think are the interesting cases, that are, in medicine a lot of times, um, the concept of, don't go looking for zebras. We live in the plains of Nebraska, right? You look for horses. So we look at the common diagnoses. That doesn't mean that you won't find a zebra in the state of Nebraska, but if you're, that's at the zoo. Um, that's kind of one of the comments, and I'm sure that quote isn't exactly perfect. And if one of my attendings does hear it, I might hear about from them. But it's similar to that, basically. But the comment is, don't go looking for zebras. Look at the horses, right? That's what we see out here. And again, occasionally you do find yourself at the zoo and you will find a zebra. So there's a couple of cases I have that I think about, and one of the more interesting ones is just somebody had come in, was lightly hypoxic, needed just a couple 3 liters of oxygen, and their O2 need had gone up, and their X-ray looked like it was COVID or infectious, and all the COVID stuff came back negative, and the influenza and the respiratory viral panel was negative, and all the cultures were negative, and their white count was actually a little bit low. It was just one of these cases that was kind of standing out a little bit. So I happened to get involved and look at them, and you get some blood tests back, some lab tests had come back, and a couple of things had popped up that were just slightly abnormal. And you kind of start looking at this patient and think through the list. And then they had one little episode of hemoptysis, which was not a commonality, or coughed a little bit of blood. Not much. Oxygen needs didn't change. So of course, there's some parts of the workup that we do. But this is a person who actually was a zebra and came back with what something called systemic lupus erythematosus. And it was kind of a diagnosis that we made in an outlying hospital. And this was an inpatient that needed to be there. This was somebody who needed to be inside the hospital. This did happen to be kind of during the pandemic. And they really didn't have an option to transfer. So it really was one of those cases where they didn't really have the option to really get out of there. So what it kind of comes down to is a couple of phone calls with a rheumatology colleague, but making some adjustments and medications and actually putting them on steroids, getting their oxygenation to improve enough. And some of these treatment approaches that actually got this person outpatient, and then back into clinic, and sort of adjusted, managed medically, but able to manage this person in that way. I would tell you 10 years ago, there's not a chance that person didn't end up with massive hemoptysis and transferred. And that's something that, again, just kind of eyes on. And sometimes you need more eyes on, but you have three, four sets of people looking in on it. We sort of, again, out in the plains of Nebraska or Iowa or Kansas or whatever, managed to spot a zebra. Those are some of the cases that I would tell you that, and it's not to say that we don't have some more, because my partners and I, we all compare. We all have a couple of these little one-offs here and there. but neat cases where we've been able to identify an atypical process fairly early and actually mitigate the situation, manage the situation, and keep them not only home but then manage this outpatient.
Yeah, that's cool. I didn't know we were going to go down the zookeeper route, though. I'm going to have to chalk that up as, maybe we're going to Dr. Martin the zookeeper now.
Yeah,
We're going to have
yeah,
to,
Yeah.
there you go.
but it's interesting, and I think the other, I'll flip that perspective just a fraction in terms of, I think in talking and knowing both sides of the equations, and my background's critical care for a lot of years, and I think that one of the things that I think is amazing about this type of program is when you bring somebody like yourself into the mix. And to your point, let's put it this way: through the lens of Dr. Martin, what is a zebra? Uh, or let me pull that back. What is a horse in
Hmm.
the state of Nebraska? To Shane might be a zebra with one leg or
Yeah,
two legs or a unicorn or something that you would have to go to the zoo to find.
right,
And but for Dr. Martin, it's just a horse, right?
right.
So I think and that's what's so fascinating about uh, having that level of expertise that comes in right by your side to say, Shane, hey Shane, that's just a horse, man. You just need to settle down, and you're going to be fine here, right? This is okay. We'll work through this, but hey, listen, you're on the right track, and everything's going to be fine. And or in which case, by golly, that is a zebra, and boy, I haven't seen one of those in a while, and the good news is you're in good hands, and here's what we need to do with that, and you certainly identify that zebra versus when it gets to the point of sort of digressing on the loose, and finally the zookeeper tracks him down at a different facility to
Right.
get him in the proper venue. But yeah, I think that it's, and incidentally, I think what your comment on the transfers and preventing the transfers, particularly in the pandemic, is a big one because certainly today, although theoretically the pandemic is sort of on the back end, or we're
Hmm.
moving forward on that front, at least in different variants. We're still seeing significant capacity issues across a lot of these larger tertiary centers and regional hospitals, and it may not necessarily be a bed issue, but it could be but nonetheless a capacity issue because maybe they're only staffing
Hmm.
75% of their facilities. So we've definitely still seen in many pockets of the country, and others are worse than other. Certain pockets are worse than others, of course, but certainly scenarios where it is difficult to transfer those at least perceived to be zebras out over to folks like yourself. So it's definitely still a significant need, and I'm interested in your thoughts on moving forward in the future from your perspective. I'm interested in your timeline on doing the bronchoscopies virtually, where the arms come out and kind of do everything virtually. I'm interested in your thoughts on that. But what are your thoughts moving forward? In terms of what many folks have described, the virtual strategies are here to stay, and this is just part of practice. It's really not telemedicine anymore, it's just medicine, and then this is how we do it. What are your thoughts on that?
Well, I absolutely think that this type of a process, I think it's going to evolve a little bit going forward. I think every system. I mean, if you don't change your mind on something in the future, right, you're bound to be a hypocrite at some point. So, yes, I think this is here to stay. This is not something that's going to go away. And to be completely honest, um, the field of medicine's changed ever since 2020. It's not going to go back to exactly the way it ever was. Um, it's going to be in whether it's space limitations or personnel limitations, or in certain instances, there's I know some systems that have smaller systems, but if they've lost a certain physician, they've had to shut down a whole service line. They've lost that specialty period. Those types of things, I think the strategies are going to have to be adaptable and something you can implement and almost flip like a switch on a light. You need to be able to be, I think, quick to respond and act in accordance. And you're going to want to have broad-based networks. You're going to want to have the ability to have a large pool of providers to pull from to help cover those types of things. We're fortunate we structured ourselves, especially during COVID and prior to that, but we really structured ourselves such that we were able to really take on a pretty significant amount of growth in a rapid or really short period of time. Um, I think going forward, adaptability is going to be key. I think the ability to deal with, in our instances, some of the stuff was just dealing with multiple electronic medical records, being able to bounce back and forth from whether it's Paragon or McKesson or Cerner or Epic, and understanding all of those, where's my lab, where's my X-ray, finding all those things. Adaptability is going to be key. I think virtual strategies are definitely here to stay. I think gaps in service, especially from a specialty side, we really need to focus on limiting that, and maybe just eliminating those gaps in the specialty service side. Might be difficult to do so, but it doesn't mean we shouldn't try. Those are definitely places that we need to work on. I think in the future, the better we integrate as multi-specialty, I think that's really, again, that's that sort of that, in my opinion, sort of the next evolution is sort of having the virtual strategy that is, we can fill not just this gap, but maybe that other gap. And if things change, then, the gaps change. Well, the personnel shifts, but we need to be able to be multi-specialty integrated. I think going forward, those are going to be the things that really advance what we're able to or capable of doing.
Yeah, I can't agree more. Well said, and it's absolutely the future and our vision, and along with your vision, and the evolution of the programs has been phenomenal, and the inclusion of the pulmonary program as part of the comprehensive suite, along with the newer service line coming out in terms of nursing and sitting and all of the components included in a seamless fashion, it's an exciting time, and it is the future, and we've been fortunate enough to be in that wavelength for about 10 years now, but it's absolutely a need, and on behalf of all of the patients that you and your team have cared for, the hundreds and hundreds and hundreds of consultations over the last 7 years, they thank you from the bottom of their hearts. I know they do. The amount of money saved in terms of transfers and productivity retained in the local communities for families not having to travel to visit with their loved ones in the tertiary center is amazing. The positive ROI effects for the rural hospitals, they thank you. And I can't emphasize enough the impact that you and your team have made in healthcare in general, and in Nebraska specifically, and soon to be multiple other states. But certainly the impact has been significant. And I want to appreciate your time without a doubt, and your willingness to come on the show and spend some additional time with us, and educate us about zookeeping and zebras and those sorts of things. I mean, that's really an important. I got a bonus on as part of this discussion, but really, no, seriously, Dr. Martin, I really appreciate it, and I can't thank you enough for participating on the podcast today.
Thank you very much. I appreciate it, guys. Thank you. I'm hoping this is hit some people's ears that really appreciate the content.
We would like to thank you for joining us today. Our promise to you, the listener, you will be inspired, or at a minimum find value in the information shared in this podcast. Please offer a comment or offer feedback so that we can improve this podcast and better meet your needs. Please remember to share this podcast with others that you feel may get value out of this by listening. And it's always helpful to subscribe to the podcast channel so that you're aware of future episodes and releases. In addition, if there is a rural health topic you would like to have covered on this podcast, please leave us a comment, or you can send an email to pulse@teledigmhealth.com. That's pulse@teledigmhealth.com. For more information or general inquiries, please visit teledigmhealth.com.